presentations. I'm going to introduce our three presenters and then turn it over to our first presentation. We have Isabelle Mendez Nyemba, who is a dedicated health and economic development specialist. She has over 15 years of experience managing and monitoring programs in Namibia across the health portfolio. She's worked in HIV, sexual and reproductive health, OVC programming, TB care, malaria treatment, and WASH programs. She's currently working as the chief of party at IntraHealth Namibia, and she oversees the KP STAR project. So she will be our first presenter. We'll then hear from Akilulu Shomoro, who tells us his heart is constantly beating to better serve and understand the social, economic, cultural, and psychosocial challenges of the communities where he works and lives. Currently, he is the executive director for Love in Action, Ethiopia. He's one of the founding members of this organization, and he's been working in this field for 17 years. We will then hear from Gerald Ntale from Uganda. Gerald has degrees in psychology and development studies. He also has training in social work and social administration. He's currently the deputy chief of party for a USAID Uganda activity known as Improving Care and Resilience for Children and Youth in East Central Uganda, or iCare. And he works at the Multi-Community-Based Development Initiative, or Mukobadi. He has been working in this field for over 12 years, especially in the HIV programming and DREAMS and OVC, design, management, and oversight. So I will turn it over first to Isabelle to start us off on her experiences in Namibia.
Thank you, Debbie. As introduced, Isabelle Mendez Nyemba, working for IntraHealth Namibia, KP STAR project. So I'll be sharing the experience of the KP STAR project on enhanced collaboration with public health facilities for sustainable HIV prevention, treatment, and care for key population. Next slide. Okay, sorry. Can I take you back? Okay, the outline of my presentation is I will talk about the background and also look at the methodology, result, and finally the conclusion. Thank you. Next slide. Okay, on the background, I think looking back on the key population program, there are actually barriers on KP-friendly services at public health facilities. So it was actually critical when the project started to ensure that the public health facilities are KP friendly, also in view of sustainabilities beyond donor funding. So healthcare workers lack of knowledge impeded key population friendly services at public health facilities. So we're asking why the key population were not accessing services. So over the years, and especially last year, we then found out that this was one of the barriers to health, to access KP friendly services. Healthcare workers' negative attitude toward key population. Apology. Okay. My apology. Healthcare workers' negative attitude toward key populations at health facilities has led to low uptake of HTS services by key population. And because of that, KPs have avoided accessing HIV services due to fear of stigma and discrimination. So to address challenges faced by KPs, sensitization of KP STAR project health needs, including HIV prevention services, was conducted at various districts, regions within the country. Next slide, please. What were the methodology? What did we do to ensure that the KP community, the KP client have access or are accessing services in public health facilities. So as a project, we've done a lot of sensitization meetings with regional management teams, district coordinating committees, and healthcare workers at public health facilities. So it was critical, especially starting with the regional management team, because at times we experience staff turnover at the public health facility. So the senior management team, which we call regional management team, were sensitized on the project to ensure continuity of training to public health nurses or healthcare workers that are joining the system. We've also conducted trainings of healthcare workers on KP-friendly health services. We've also introduced quarterly technical working groups. So we established technical working groups at in the various district or priority geographic areas where we are implementing the project. So the technical working group comprised of KP-led organization representative, primary healthcare supervisors, nurses in charge of health facilities to discuss challenges related to linkages of KPs and devise ways to improve service delivery. So within this technical working group, a lot of discussion goes on, and also nurses from different health facilities, nurses in charge, are also able to share their experiences with in the technical working group. So there's also continuous feedback on the project progress, challenges, and recommendation at the technical working group level. What the project has done also is to introduce case managers and peer educators at public health facilities. So at the moment, the case managers, the peer educators under the project are well known at the facilities. So there's a component of very good relationship between the different cadres. Next slide. Okay, over a period of 12 months, as indicated earlier, the project started last year. So we recruited about 5,158 female sex workers in the communities, and of those who were recruited or under the project or mobilized in the project, 126% were newly tested for HIV. 94% of those that tested positive were linked on ART, and 28.6% of those that received services at the public health facilities were initiated on PrEP. And for the MSM, 1,809 were recruited, of which 61% were newly tested for HIV, and 104% were successfully linked on ART, and 19% of those who tested negative were initiated on PrEP. I think you can also see that there is actually more people actually turned out on testing. This is actually because of the good collaboration, the enhanced collaboration between the project from the community level to the facility. So when the services are friendly at public health facilities, we also have received the Ministry of Health and Social Services public health facility also reported the number of clients that actually went by themselves, were not referred by the project. So I think that's why there's a discrepancy between those who were recruited and those who were tested at the facility. And also maybe just to add, this result indicate the result of 4 districts out of the 10 districts that we are implementing, or where the project is being implemented. Next slide. Okay, in conclusion, I think as you have looked or seen the number that I just presented, this is a result of good, it's a demonstration of sustainability beyond donor funding. As you can see, there's one of the clients there with a healthcare worker at the public health facilities, and a picture of also or of some of the nurses during the sensitization trainings, and also some of the nurses that were sensitized waving on one of the picture. So it's critical sensitization meeting with the regional and district committee, training of healthcare workers and on KP-friendly services, and regular actually engagement with healthcare workers are vital in addressing barrier to HIV health services for key population, and also for sustainable HIV prevention, treatment, and care for key population, because the public health facilities are there to stay beyond donor funding. So if good collaboration between the public health facilities strengthen, our members or our clients will also receive sustainable services from the public health facilities, because they are there to stay. Thank you so much. That's the end of the presentation. I look forward for questions. And I think I also have my team on the call that may also assist to answer some or to respond to some questions. Thank you.
Thank you so much, Isabelle. And I love that last point. And those photos are great. You should submit them for the photo contest too. But I love the idea, right? You have to engage those facility staff and facilities for the long-term sustainability. And obviously they're such a critical local actor to be connecting with and really building those relationships with for the long run. So yeah, great presentation. We're going to turn it over to Love in Action Ethiopia. And I think Alemu Tsema is going to present. And he's a program manager at Love in Action. And I know as well we have Akilulu on to help as well. So over to you all to present for Love in Action. If you can take yourself off mute.
Okay.
And if you can put your video on, if the bandwidth is a problem, of course, turn it off, but we'd love to be able to see you while you present.
Okay, thank you. Can you turn to slide 1, please? Thank you. Good afternoon, everyone. I am Alemu. I am working as program manager in Love in Action Ethiopia. This is an abstract entitled Tactical Engagement of Key Stakeholders, written by Mr. Aklilu, the Executive Director of Love in Action. This picture portrays the three sources of power contributing to the project success, namely key stakeholders, staff, and beneficiary. Please, next slide. Next slide. So the contents are backgrounds, core problem of key stakeholders, then underlying cause of this problem and the needs of LEA project. Then we will see intervention solution designed to the problem. After that, we will see the result gained and lesson drawn from the new intervention. Finally, we will see the strategic action for workers. Next slide, please. So to give you a highlight of LEA, LEA has been serving the target community in Ethiopia for the last 20 years, operating in 4 regions and 395 districts, focusing on serving hard to reach, underserved, vulnerable, most at risk, and marginalized segment of the population. And it works on 7 thematic areas, namely education and skill, education and nutrition, skill and education, and environment, agriculture, food security, and also we intervene on emergency and relief and capacity building. And finally, we also have a program on democracy, peace, public accountability, and good governance. Next, please. Next slide. Just to give you the highlights of the projects. Next slide, please. Yeah, to give you the highlights of the project, the specific project funded by USAID. The activity title is HIV Epidemic Control Grant for Local OVC Service in Gambela. Its goal is to contribute to the 3 national goals of 95 by 2025. It has 2 strategic objectives. One is to increase access and demand to family-focused HIV services, which has 3 major components: care and treatment, HIV testing, and OVC mitigation. The second strategy objective is, in fact, to strengthen data utilization. Next, please. As you may see from the summary of this table, despite COVID-19 and other specific problems to the region, FY21 was a high performance year for LEA. 74% of the indicator registered more than 100%, and the remaining 26 between 80 to 99. This is a really outstanding performance we have achieved during the year. Next, please. This picture here is the main agenda. The main agenda is actually, the title is Tactical Engagement of Key Stakeholders. The operational definition of key stakeholders is all key project-based groups, offices, clubs, and committee, which can assist the project directly and had predetermined role in mentioned in the work plan. And we will see the list of key stakeholders. Next slide, please. Next slide. This is just to give you an information on the photo portrait that the contribution, sacrifice, and commitment of the key stakeholders, the previous slide, I mean, in a harsh climate in Gambela. And the core problems are, in fact, before seeing or look into core problem, this busy slide shows the 26 category under which subgroups are and committee are actually organized. For instance, in the first line, we have quality improvement team, which have 8 subcommittee, which involve actually 40 individuals. Next. So to summarize the stakeholders, we have 26 categories, which are also 280 different layers involving 1,142 individuals, of which 10 are at committee level, have 97 subgroups involving 752. So what are the problems with this group? Leah tried to identify 3 major problems. One is the organization of the 280 stakeholders were not systematized. The second problem is sometimes their relationships are very complex. And the third one is the key stakeholders do not make long-term contribution and influence the decision of the project. Next, please. Next slide. So I also try to identify the causes and the needs for the intervention. The causes are summarized into 3. One is this system have not given attention and did not have well-structured independent line of command. Second cause is there was scarce resource to empower them. And the third one is the fear of politicization of the role of the key stakeholders. And the needs are Leah cognize the influence and significance of stakeholders. Leah wants
Alemu, I'm having a challenge hearing you. Maybe if you take yourself off video, we can hear a little better. Yeah, I can't hear as well. You may be frozen. I don't know if Akililu, if you're able to jump in and cover the last portion of the slides.
Yeah, can you hear me?
Yes, yes. I think it's the screen froze for Alemu.
Yeah, I think he stopped on the needs in the project in regards to the new structure. And concerning the needs, Leah understood that the key stakeholders has high influence and high significance, especially as we are working on hard to reach areas, and they have meaningful contributions in the project. The second one is Leah wanted to respond to proper management of this complex relationship and communications between the project and or Leah and the key stakeholders. The third need was we wanted to change the complex relationship into dynamic and very structured one that all key stakeholders can contribute and be effective and be visible. These are some of the needs which pushed us just to think about this new structure. Please, next slide. In regards to the intervention that we designed just to solve this problem, on the first place, Leah usually followed adaptive management methodologies and introduced a new organogram for key stakeholders management. We named it Organogram for Integrated Key Stakeholders Management, IKSM. This structure reconstructed the uneven and irregular engagement of the key stakeholders into one line of command. That means we have been working with 218 boxes or types of stakeholders. We just reduced the 218 boxes into 15 boxes only. Then this structure has two layers or two dimensions. The first one is the vertical category. Then the second one is the horizontal one. On the vertical one, you see the regional, the SNU, and the community level arrangement of these stakeholders. On the horizontal one, there are a service delivery line and the quality improvement line were arranged separately under the two of which care and treatment, OVC care and HTS or HIV testing service were distinctly treated and structured. Next slide, please. This is the structure. As you see on the top, you find technical working group. It is a kind of a supreme organ. We arranged or we organize these groups at regional level. Under this, the supreme organ, we have two core teams. The first one is service delivery core team. The second one is quality improvement core teams. Then below the core teams at regional level, we will have task forces at the district level, or we call it Warada. At district level, we have task forces. These task forces are arranged just based on the three major components of our projects funded by USAID that are care and treatment, OVC mitigation, and HIV testing and the counseling. Then we will have different stakeholders at the community level on the last part. Next slide, please. These are some of the roles and the arrangements or the organization and the formation of each of the layers or the boxes. As I said, on the top, there is a technical working group. This technical working group is organized from signatory offices and relevant CSOs and the PLHIV associations and the regional HABCO. So this organ or this box or this structure is responsible just to give a leadership support to all the structures working on the project in relation to the key stakeholders. Next slide, please. In regards to the results and the lesson we draw from this process, the first one is improved project performance. As you see on FY20 performance on the previous slides, almost 74% of the total indicators are we accomplish 74% of the total indicators above 100%, and the remaining 60 or 26% is between 88 and 99%. So this structure, the new structure, helps us just to improve our performances. The second one is it helps us just to have a kind of cost optimization and effectiveness. If you see the cost share of or the cost contribution of the 1,142 key stakeholders involving in the project, if you calculate to USAID per person per day in 52 weeks or in 1 year, these stakeholders contributed about 118,760 USD in monetary values. The new structures also increased visibility of some of the key stakeholders like women groups. It also provides distinct lines for each of the key stakeholders. In most ways, it is stresses and it brought clearness on collaboration and segregations. And also the new structure promoted restricted and productive engagement of the key stakeholders, and it reduced role conflicts, and it also enhanced representation, influences, and additional roles like RDQA, and increased knowledge on key stakeholders, especially in LIAE. We are trying to design SOPs and some kind of tools just to manage the key stakeholders management in LIAE. Please, the next slide. Finally, the strategic actions that we are thinking is just LIAE recommended these new strategies just to enhance performance and operation of HIV programs in Gambela region, as well as other programs in Gambela. We want also to recommend the same program for other programs in other area of Ethiopia or in the country. And if there are chances and if we can customize it, we recommend also this new structure to other countries if it aligns to their situations. And we want to also in the future to prepare details of the SOPs and the integrated for the integrated stakeholders management process, for the integrated stakeholders approach process management. And finally, we want to conduct a kind of operational assessment just to see the effectiveness of the new structures and its contribution to the system and performance improvement. Next slide, please. These are some of the acronyms just to better understand the details in the PowerPoint. And finally, thank you very much for the opportunity provided and for the time you gave us. Thank you so much.
Thank you so much
for the inconvenience. Yeah.
Thank you for joining, and thank you, Akilulu, for stepping in, and thank you, Alemu. I think we see you back on, so I'm sure you can address questions as well. We have some coming in the Q&A, so please, others, if you have questions, include them in the Q&A on the bottom. You'll see the icon there, and we'll get to them at the end. And to our colleagues in Ethiopia, I know you're dealing with a lot in country right now too, so we really appreciate you being here, and stay safe. So we'll turn it over now to Gerald and Tale, and he will talk through our last session, our last topic before we open up for questions. Over to you, Gerald.
Thank you so much, Deborah, for moderating this session. Good evening, good morning, good afternoon, good evening, ladies, gentlemen, and others. As earlier introduced, my name is Gerald Ntale Kasula. I work with a local organization in Uganda called Multi-Community-Based Development Initiative as a Deputy Chief of Party, and we're implementing an activity funded by USAID Uganda called Improving Care and Resilience in East Central Uganda. So I'm going to present on the partnership with faith-based institutions to improve viral tracking for children and adolescents living with HIV in OVC programs. So slide forward, please. Okay, so this is a bit about our organization. Earlier noted is multi-community-based development initiative, Mukobadis, the local organization I work with, and we're implementing a USAID funded activity called Improving Care and Resilience. So the team that you see down here are the authors we worked with, of course, being the lead author, and supported by the other people you see downstream here as sub-authors. Move forward, please. Okay, so a bit of background. We are talking about treatment outcomes in this under this session, and treatment outcomes are diverse, but here we shall narrow our discussion to viral monitoring and viral suppression. And of course, you can see that it is stagnant nationally at 76% for all children and at 81% for the OVC. And there are many factors that can explain the stagnation. So one of the factors is uncoordinated and insufficient service packages, non-adherence, and treatment interruptions, coupled with overrepresentation of children by treatment supporters, inaccessibility and treatment fatigue, stigma, non-disclosure, and retention on suboptimal regimens. So again, alongside on non-supportive caregivers, undernourishment and socio-economic factors such as poverty. So this again requires that we build strong, formidable, sound partnerships, and we ensure integration of clinical and community services. Slide forward. Okay, so this is the methodology. And the big question here is, what did we do to ensure that we break through with the faith-based institutions? Of course, I want again to paint a picture that faith-based institutions occupy 60% of the facilities that we work with in the East Central region. So it is important that they are prioritized as key stakeholders as we serve children and adolescents living with HIV under the OVC program. So this is what we did. We held a couple of meetings and we had key informant interviews. We had workshops with high-level leaders in the Catholic Church, especially because our case study is likely focusing on the Catholic Church among other denominations. So we also held a meeting with the health coordinator, the chancellor, and in charges. So these meetings were geared towards understanding the scope of work for the OVC partner and how we want to work with them. Then we also continue to have focus group discussions, of course now a bit smaller than the previous meetings that we had in box number 1. So here to really try to understand the structure, the rules of engagement, and cultivating a scope of work. So again, we continue to document lessons, adaptations over a period of 7 months while dealing with the high volume facilities. Next. Okay, so what you see here is that painstaking journey, but very rewarding though. And it takes us through the step-by-step process that we followed for us to realize positive outcomes for the good of the OVC. So when COP20 was starting, sometime in October, we mapped health facilities and got to know who the founders were and the sponsors. So there were diverse categories. Some of them were founded by the government, others by faith institutions, others by private sector. So we got to know what these facilities were and the founders, and of course get to understand how to deal with them. So in January, we held a meeting with the diocesan health coordinator. This is the person who is next to the vice chancellor and who communicates direct to the bishop. So knowing that the Catholic Church is highly structured, highly bureaucratic, we needed to go through this layer and to engage with this lady, tell her what we want to do and how we want to work with the Catholic Church. So from there, we held a meeting with the bishop, and the gatekeeper to that meeting was the diocesan health coordinator and the chancellor. We went ahead to hold meetings with the hospital administrators and the health facility in charges. And in this, we cultivated the scope of work and schemed for what it is that we're going to do jointly with the Catholic Church and the health facilities founded by Catholic Church. So again, it wasn't that easy. It was quite very difficult, a lot of questions, like we shall see in the challenges. and the best practices. So we shall be able to see how exactly this was challenging. But again, just to note, it was very difficult to get to this level. So that was preceded by signing an MOU where we agreed upon the scope of work and agreed on the budgets. From there, we had a formal relationship. And again, after talking to the diocese, we were able to win their support and their favor. We were handheld to the health facilities, and it is now the diocese speaking to the health workers to give us the necessary support. But I mean, before that, it was very, very difficult to work with these facilities because their funding modality preferred was quite different from what we have within our contract. So like what you can see here, we realized some results, but you allow me to speak to the results in a later slide. Slide forward, please. Okay, so this is the result. Due to the systematic engagement, the following results were triggered. We were able to cultivate a collaborative implementation plan where iCare agreed on the key roles and responsibilities and the scope of work, and the Catholic Church did the same. So after a back and forth movement, we're being chased from the facilities, we're now able to come together on a round table to agree on the implementation plan and the mode of work. Again, as a result of that, we realized 100% quality of data because we're now allowed access to the health facilities and the health records for the CLHIV that we intended to support. Then you can see on the third bullet that from 64% to 92%, we increased enrollment of CLHIV into the LVC program. All of us on this call may be knowing that the COP20, because we are discussing results in COP20, COP20 required that we have 90% of CLHIV on treatment enrolled in the OVC program. So you can see that we really surpassed that COP target as a result of cultivating a very strong, formidable working relationship. Again, you realize that we have a 92% CLHIV supported to monitor viral load and an improvement from 34%. So you see that we moved from 34% as a baseline before we engaged with the Catholic Church through formal ways to 82%. For us, this is a very big success that we are proud about. And then you can see that we have 88% viral suppression, way from 78%. Slide forward, colleagues. Okay, so best practices. Here the big question is, what are the game changers? How did we do it? Because we are here to share an experience. What are those magic bullets and the tested strategies that we employed for us to be able to penetrate the Catholic Church? So this is summarized in 4 words. The first one is we need to remain consistent, persistent, and resilient, because from time to time we could go to the different offices and they could bounce us back. But we're consistent and we're persistent, but also we remain stuck with our words. So again, this can be talked about in terms of what you see here. We need to share information and do not use backdoor. The Catholic Church believes a lot in maintaining legitimacy, not really concealing information. So we had to share information openly about the available budgets, the funding modalities, and what it is that we had come to do with the CLHIV in their health facilities. But also, it is critical to acknowledge and respect chain of command. Just like I've taken you through the painstaking journey, you could see that we had to go through all the layers of leadership so that we don't, skip some ladders. So it is critical if you're to engage with the Catholic Church or the faith-based institutions to know the rules, the do's and don'ts for the institution. It is critical also to build relationships because along the way, again, the diocesan health secretary was the person leading us all the way to the bishop, to the vice chancellor, and even handholding us to the facility. So building relationships is very critical, and we shouldn't be seen to be coercing or being dishonest. So the aim here was to have a win-win situation to serve the CLHIV who are under the faith-based institutions. Slide forward, please. Okay, so these are the challenges along the journey or along the path. Earlier noted is we had a challenge around bureaucratic processes. And again, as ICAO respected the bureaucracy, we did not take it negatively. We got to know the rules of the engagement, and we had to dance to the tunes of the Catholic Church. Then, of course, we had restricted access to data. Of course, without accessing data, it was difficult for us to enroll OVC and serve them. Then there was delayed enrollment, viral tracking, and service provision. There was preference of sub-granting model than the model that we work, because in the current COP and the previous COP, we are not, in our contract, we don't have powers to sub-grant, but the church preferred that we sub-grant them than merely supporting their staff to work with us in the different activities. So again, you can see that we have the corresponding mitigations. To address the issue of bureaucracy, we had to hold partnership meetings where I told you we shared a lot of information about what it is that we're intending to do and how we want to do it. Then, of course, that was also supported by signing of MOU and developing joint implementation plan. Then again, we continue with joint service provision, and then harmonization of pay structure. The church never wanted us to disorganize their pay structure. So it was important that we leverage, we fit within their structure and leverage on resources. Slide forward, I'm about to finish. So in conclusion, we are saying that for us to have sustainable, long-standing, sustainable service provision, it is important to harness collaborative linkages to catalyze improvements in viral monitoring, of course, alongside other services for the OVC, which eventually paves the way for rapid expansion of treatment options and models. And then we need to be able to keep afloat with bidirectional referral for us to be able to realize positive results for the OVC, especially while working with the faith-based organizations or institutions. So colleagues, I thank you so much for listening, and over from me. Thank you.
Thank you so much, Gerald. That was a fabulous presentation and really impressive results. I think through all these presentations, it's really exciting to see these kind of systematic interventions that get at increasing engagement with stakeholders and relationship building. But not just that that's the outcome, but the outcome has actually been improved HIV results. So thank you so much for sharing that. It's really impressive. And we have a bunch of questions in the Q&A. We have a few minutes left, so hopefully we can get through all of these. Maybe I'll start with this bottom last question that came in for Gerald. I think this is a really interesting one. The question is, did you have targets, PEPFAR targets from October that you needed to report on? And if yes, were you meeting the targets? And if not, how did you overcome the challenge of not meeting the targets? And I think this last point is a really good one. The question is, or the comment is, I find that as implementers, we often skip proper stakeholder engagement because we need to meet the targets set by funders, in this case, PEPFAR, each month. So how did you address meeting the targets while still taking the time to build the relationships and make these connections? Gerald, if you can, over to you, and you're on mute right now.
Okay, thank you so much for the question. Most of the facilities actually are under Ginger as a district, and so our performance was suboptimal for Ginger district, but we were able to cover up with other districts where we're working very well. So I must accept that we were very challenged meeting the targets for Ginger, where most of the high volume facilities under faith, under Catholic Church was based. But we were able to compensate with the other facilities in the other districts that were very compliant. And again, like you could see on the journey, we continue to engage. So we had a team, a partnership building team dedicated to ensure that we sign off this agreement. And so you realize that in May, we signed off the agreement and we were able to really develop a catch-up plan. So by the end of COP20, were able to achieve fully on the targets given to us by PEPFAR. Thank you.
Great, and I think that points to sort of a lesson for all of us, right? That it's important to have that time to build relationships before you get moving on all your target and target types of service delivery work. So I know we don't often give our partners enough time to do that, but hopefully we can have a dialogue where you say, this is critical for our success. So give us, you know, the few months that are needed to do that or whatever is required. Thanks for raising that question and thanks for sharing the response. I'm gonna put a question toward for Love in Action. I think Alemu, you're back on, or Akililo, you can respond. The question was around the organogram for the key stakeholder management structure. The question is this internal staff or these are not part of employees? And to tag on, I had one other question related to your approach and sort of how you're monitoring it going forward or how you are supporting it to be sustainable going forward. I'd love to hear a little bit more about that. So if you could tell us a little bit more about the organogram for the key stakeholders that you used in Ethiopia, and how you can make sure that it is a lasting structure into the future. Alemu, are you gonna respond?
Hello?
Yes, we can hear you.
Can you hear me? Yeah. Thank you. It's an important question. You know, we have been actually using or working with these stakeholders, and what we try to make in this on this system is to make them systematized. So even though they are not our staff, they are actually part of the project. They are actually, some of them are even beneficiaries. There are HIV associations, and the structure has actually provided LEA and the stakeholders or the opportunity to perform better and to sustain the performance, as well as, you know, the role of the key stakeholders. So that was, you know, as we mentioned, there was a problem to be systematized, and there was a complex, you know, relationship, and their role was not actually as expected. So to make this, you know, problem, to overcome this problem, you need to, you know, systematize them. So in the process, we need to have, you know, a sort of management system, and we came with the new organogram, which is actually presented today. And with this, we have been working for a number of months, and we have been also successful, as you saw in the performance table. We have actually registered outstanding performance, not only because of our staff, but because of this, the engagement of these key stakeholders. So this can be a good opportunity to sustain the collaboration, the partnership between LEA and the key stakeholders. Over to you. Thank you.
Great, thank you for sharing that. I think we have time for just one more question. I'll pose to Isabelle, and for others, if you can look at the chat or the Q&A box and even respond to some of the questions that we didn't get to in writing in the chat or in the Q&A section, that would be great. But for Isabelle, there's a question about how the level of training for the case manager and peer educators. And I think this is also a great part of the question. Has there been any lobbying by the TWG to influence inclusion of KP sensitization and competency in the healthcare worker trainings? Again, I think that's another way to push to get this to be sustainable kind of support and part of something that all healthcare workers are receiving. But it'd be great to hear your thoughts on that. And if you can add in anything, you can see some of the other questions in there around the increase in MSM that have been recruited. If you can explain, does this mean CSWs or what, and how do we relate them to KP activities and services, and anything on the performance piece? Why do you think there was a performance difference between FSWs and MSM? A lot in there, if you can cover in 2 or 3 minutes.
Okay. Thank you. Okay, on the first question, I think it's on the training level. For our case managers, they all have grade 12. For peer educators, it's usually sex workers themselves, or friends of the sex workers, or someone who knows where to get, who's part of the sex worker community, who know how to identify them and who know the hotspots. And on the issue of the technical working group question, I think for Namibia, it's a milestone. A lot has been done. A few years ago, it was not easy to talk about issues surrounding key population. I think the government has done a lot of initiatives, although issues of key population might not be necessarily included in the training curriculum or in the training for the nurses, but the National Strategic Framework on for HIV and AIDS response talk about the issues of key population. That's a national document for the country, and that shows commitment from the government part to ensure that the key population receive health services irrespective of who they are. I think from government stand, I think that's a very good thing. But however, there was a need, and also still a need, for continuous sensitization to ensure that even those the new or the upcoming healthcare workers have access to this information. At the end of the day, they still have to implement what the National Strategic Framework says, meaning that there is that ownership, that willingness from government to ensure that services provided irrespective of who they are. And on the question of why perhaps we might have reached more female sex workers than MSM, in Namibia, generally we find more female sex workers than MSM. Even the targets given by the donor, mostly female sex workers are more comparing to the MSM target. And I think there was also a question whether there's challenges in getting or reaching to the MSM. We have not really experienced challenges because most of our peer educators, case managers that are reaching out to MSM, they're MSM themselves. So we really don't have, we're not really experiencing challenges. I don't know whether I've left out one of 2 questions. Yeah.
Well, thank you all so much. If you can, in the next minute, there's some questions that have come in the chat box, just to quickly look through those and respond if you can in writing. But just to say a huge thank you to our 3 presenters, and thank you all for joining and your great questions and engagement in the chat box and the Q&A. I think what leaves me from this session so excited is that we can do these kind of more structural or systemic kind of interventions and actually see improvement in our HIV outcomes, which again is always hard to show, but being able to document that really demonstrates the value of connecting with stakeholders, building relationships and trusts, and really listening to those that we need to engage with to have better outcomes. So I really look forward to sharing your presentations with others I know, and I think this can help us advocate for having the space to do that ahead of just jumping to the target delivery. So thank you all so much, and hopefully you have good subsequent sessions, but really appreciate everybody sharing on this one, and thanks for your contributions. Take care. Goodbye, everyone.
Goodbye. Thank you.
Thank you so much, Debbie. Thanks. Bye.
Very much.